you all for coming. So this is the third presentation on trauma-informed care. Like we mentioned last week, this week we're going to focus a little bit more on the biological impact of trauma, how it impacts children at different levels of development, and its impact on specific areas of brain function.
And I am Wendy.
I'm Shirley.
And we're the two psych interns who are in inpatient and day treatment here in West Dallas.
So an overview of today's presentation, we're going to
Shirley,
talk
can
about...
I just ask that you speak up just a little?
Oh, sure.
Okay.
So today the overview is the role of relationships on the development of emotional regulation. We're going to talk about the stress response system in the brain, early brain development, the impact of trauma on brain development, and the impact of trauma at different stages of development. So how trauma looks when children experience it at school age or from 0 to 5 versus adolescence. And then we'll wrap up by talking about how this information can inform our treatment. So far, the focus of each of these presentations has been about understanding the various negative impacts of trauma, but the first few slides we're going to kind of take a step back and briefly discuss what normal healthy development looks like and what we need for normal healthy development to give us a better understanding of trauma. Okay. So children need consistent, predictable, enriched, and stimulating interaction in the context of attentive and nurturing relationships in order to achieve full potential. Are we good?
Yeah, we're good.
Okay.
Some high-tech gadgets here.
I know.
Early adversity alone is not problematic, but rather the absence of sufficiency of early protective relationships which serve to buffer adversity. The lack of nurturing relationships or environments that are chaotic and or cognitively or relationally impoverished negatively impact brain development. So as we kind of discussed, it's not just the trauma itself that has a negative impact on brain development and on development itself, but it's also the lack of positive influences like positive relationships, nurturing, access to things like toys or educational materials, right? All of those kind of go together to impact development. A child's relationships with others not only provide a model of how to respond to stressful situations, but also impact the foundational brain structures that regulate the stress response system. So it's not just, providing an example for children how we respond to stress, but those interactions in themselves are what is developing the neural pathways that help a child regulate their emotions on their own. So consistent nurturing responses to a child's stress reactions create the foundation of healthy emotional regulation by building those neural pathways. Inconsistent, abusive, and or lack of a response to a child's stress reactions can lead to a constant state of hyperarousal. So when a child is in distress, if we respond abusively or just fail to respond at all, the child never learns how to regulate. They're never calmed. So those pathways, they're just not going to develop the same way as normally if we were to respond in a way that's nurturing. The caregiver's response to a child's distress not only impacts emotional regulation, but it's also the foundation of healthy attachment and trust. So not only are we building those neural pathways and modeling the kind of behavior and response that we want to see in the future, but when a child knows that if they're in distress and we respond, that's kind of the foundation of trust and being able to, trust in another person and trust in your caregivers, right? Okay. So again, when we think about stress, in these last few presentations, we've talked about kind of toxic stress and trauma and the negative impact of stress, but there's also good stress, right? When we experience a little bit of stress and it's not incredibly traumatic and it's predictable and we're able to kind of calm down afterwards, that's how we build resiliency. That's where we learn. That's how we build our confidence, right? So like stress before taking a test is kind of stressful, but at the same time, once we face it and we manage it, the next time these kind of situations aren't as bad. The more we face stress successfully, we're building resilience, right? So when stress is limited, if it's moderate, and if it's predictable, and in the context of a nurturing relationship, we're actually promoting resiliency. But when you have stress that's chronic or severe or unpredictable, and then there's no mediating factor like nurturing relationships to buffer that, that's when you start to see trauma and traumatic stress. Okay. And this is, we've kind of discussed this before, the pattern stress reactions that happen in response to trauma. So when a child freezes, their body is trying to assess the threat and decrease their visibility. So they're just kind of freezing, holding still, making themselves less vulnerable to threat. And then the flight or flee response, when we see that occur, we typically call it like the fight or flight or fight or flee. You're going to see an increase in heart rate, adrenaline goes up. That's the body prepping itself to either fight or run away to escape from these threats. Disassociation is another response we might see when the threat is inescapable. So when they're experiencing that trauma and can't fight or run away. So you'll see the heart rate decrease, and then the brain floods the body with opiates to kind of mediate that stress response. Repeated experiences like these can result in the stress response becoming wired in over time. When we say wired in, the more often this happens, the stronger those neural pathways are. So this becomes the most likely way that a child is going to respond in these situations, simply because that's what they've learned to do over time. When the freeze, fight, or flee stress response is the body's way of dealing with acute stress, it's not meant to be activated all the time, right? It's only supposed to be activated when we're in a threatening situation and need to survive. But with the kids that we work with who experience this chronic, complex trauma, their stress response system is activated all the time. So everything is kind of viewed as a threat. Trauma and information processing, this is something else that we've kind of spoken about when we talked about the different symptoms of trauma or the behavioral ways that trauma might manifest. So all incoming information is processed first in the brainstem, and the greater the activation of the brainstem, so the more it's aroused, the less activated the neocortex, right? So the brainstem is one of the basic functions. So it's things like breathing, regulating sleep, and that stress response system, where the neocortex is kind of our higher thinking. So things like inhibition, social skills, being able to make decisions, all of our executive functioning, right? So in other words, it's difficult to be emotional and reasonable at the same time when that brainstem is highly activated. When these kids are perceiving threat, it's difficult for them to reason how they should behave. So they can't really take a step back and think about the consequences of what might happen depending on how they react. So at birth, the human brain is 25% developed, and the brain continues to develop over time by growing nerve cells and making connections. Most of the brain development occurs after birth and requires experience to create neural pathways. These connections are use dependent, so the most used are the strongest and the least used fade away. Therefore, the more an experience is repeated, the stronger the connections become, and interactions with the caregiver are critical to brain development. The reason that is because, one, we're making sure that they're in an environment that's safe, that's enriching, and we're also providing a response to the distress, like we talked about, and building that attachment. So when we're relating to our kids in a way that's healthy, I'm sure there are plenty of people in here who have children or maybe, have younger children in their family, and we think about what we provide for them so that they can reach full potential. I mean, we're reading to them, we're showing them physical affection, we provide them with toys, entertainment, things like that. I mean, that's intuitive. Those are things that kids need in order to develop to their full potential. But when children don't have that, they're not able to build those connections, and eventually it's going to make it more difficult to build those connections as they get older. And this developmental process allows the brain to adapt to different environments and develop pathways consistent with the environment that they're in. So early brain development, this kind of gives you a picture of a fully developed brain. And what we need to remember for Brain Development 101 is that the brain develops from the bottom up and from the inside out. And the lower parts of the brain, so like the brainstem and the limbic system, which are kind of the basis for the stress response system that we've been talking about all throughout these presentations, they're the first part of the brain to develop. And these early structures have the least plasticity, and they're the most vulnerable to adversity. And they're the ones that, these are the ones that we're seeing most affected by the kids that we work with, right? And what that means by least plasticity is it's more difficult for them to bounce back. So when you see brain injuries in adults where it's like in the cortex, so kind of that outer layer, people have far greater chances of bouncing back from that or recovering from that. While you're still able to recover from this kind of early adversity, you might see the impact forever. Like it can be lifelong. That doesn't mean that you can't find new ways to cope with it or that it's hopeless, but these might be things that you need to be thinking about down the road. Okay. So again, those different brain structures that we were kind of looking at, the brain stem, which regulates sleep and wake cycles, it interprets that sensory information that's coming in, so interpreting our environment and scanning for threat. It mediates the stress response system, so things like heart rate, blood pressure, breathing. And then the limbic system, which includes the anterior cingulate, the hippocampus, the amygdala. That's kind of the whole system that works together as far as mediating the stress response, including the brain stem. So that kind of works with emotion processing, memory, arousal, and the amygdala, which I think is kind of key for a lot of the things we do here. When you see the amygdala being overstimulated, that has to do with like fear learning, facial recognition, and it serves as the smoke alarm for the body, right? So that's what's signaling to the body that we're facing threat. So in a lot of these kids, we'll see an overstimulated amygdala where they're perceiving everything as a threat. It's very difficult for them to understand what's safe and what isn't. And then other portions that are affected by trauma are the cerebellum. That's where we start to see kids who have sensory issues where they might have a hard time. One of the girls earlier from the presentation was saying that she's had children who have a sense of their own body but not necessarily where their body is in space or in relation to others. So you might see this uncoordinated movement, or they might be a little too overzealous when they're going to hug us or grabbing us. I think some people were talking about earlier. And then the prefrontal cortex, that develops later. So these earlier structures, when you start to see kind of abnormal development, that can impact their connection to the prefrontal cortex, which mediates things like executive functioning and social skills. The impact of trauma on brain development, so to kind of summarize all of the different areas that trauma can impact as far as brain development, this ongoing hyperarousal of the stress response system without being able to return to homeostasis, so without being able to go back to being calm, can result in overall poor brain development. So we'll see delays in myelination, abnormal developmental pruning, so neural pathways that never really had a chance to develop just kind of fade away and die. Abnormal cortisol patterns, so you see these kids with these high levels of cortisol, which I'm sure a lot of the nurses in here understand how damaging these high levels of cortisol can be in a person's body. Increased neuron loss, an overactive amygdala, which we talked about how that kind of makes people feel like everything is a threat. Decreased connections in the corpus callosum, so there's not, there might be delays in communications across the lobes, and then decreased brain size. Trauma can have serious consequences for the normal development of children's brains chemistry, and nervous system. Trauma-induced alterations in biological stress systems can adversely affect brain development, cognitive and academic skills, and language acquisition. These are things that we kind of talked about in the previous presentations too, how this early developmental impairment later on can impact the way a child functions in school, their ability to communicate, their memory, their attention. Traumatized children and adolescents display changes in the levels of stress hormones similar to those seen in combat veterans, which I think is really something to think about. When we think of men and women who've gone to war and have faced battle, and we think about the amount of stress that they're facing, they've found that the same levels of stress hormones are present in children who've experienced trauma, right? The difference is that with adults, they have frontal lobes, right? So they can use logic and reasoning to tell themselves that while they might be feeling like this is a threatening situation, they know that it's not. So they can tell themselves, oh, that's not, those aren't gunshots, those are just fireworks. And they can, in a way, kind of regulate themselves, where children lack that logic. They're not able to scan their environment and see it as something other than threatening. So overall, trauma derails development. And exposure to trauma causes the brain to develop in ways that will help them survive in a dangerous world, right? So they're on constant alert for danger. They're quick to react to threats by fight, flight, or freezing. But while that helps them in a dangerous environment, that kind of impedes their ability to function in a normal environment like school, right? So if this is the way that they've learned to react, it can start to be very detrimental when they're in school or just trying to function outside of that threatening situation. And the stress hormones produced during trauma also interfere with the development of higher brain functions. So like I was saying earlier, it kind of impedes those connections to the prefrontal cortex and then later to the frontal lobes and also the corpus callosum. It kind of impacts development of that. So to kind of recap, child traumatic stress reactions vary by developmental stage. Children who've been exposed to trauma expend a great deal of energy responding to, coping with, and coming to terms with the event. That's something to think about. Not only are they trying to cope with what happened to them, just being in the environment that they're in takes a lot of energy. So sometimes when we're placing demands on kids, which I say demands kind of generally, but that can be something as simple as, okay, line up, it's time to go to dinner, or okay, it's time to go to your room and work on your binder. Those can be a very stressful demand when they're spending the entire day trying to just stay calm. So this may reduce a child's capacity to explore their environment and master age-appropriate developmental tasks. So when they're experiencing this kind of stress, it's going to make them less likely to interact with others or even explore things in their environment that might help them, have a more enriching environment. They're less likely to engage in playing with new toys or having new experiences with peers. And the longer the traumatic stress goes untreated, the further children tend to stray away from appropriate developmental pathways.
So there are definitely certain periods during brain development and the periods of brain development when it's most susceptible and open to specific types of learning and specific types of development. And when trauma occurs during those developmental stages, it can definitely look different. It can look different in young children, it looks different in school-age children, and it definitely looks different in adolescents. So we kind of broke it down, and we're going to be going through the different developmental stages, and then we're kind of outlining what are some of the key developmental tasks that are supposed to be developing in normally, just developing children, and then how trauma really impacts that development and what that can look like. So in young children, roughly around the ages of 0 to 5, it is crucial for the development of visual and auditory perception. And this is something that children definitely need later on once they start school, because these are the skills that you need in order to be able to attend and take in the information. A lot of times in school, the learning is auditory, so when you don't have these skills in place, it can look like ADHD behavior where they're not attending, when it could really just be the impact of trauma on development. Recognition of and response to emotional cues, which definitely affects a child's ability to be able to relate to others, relate to peers, adults. Attachment to primary caregiver, development of complex functions such as memory and language. So especially in younger children who are maybe pre-verbal, who don't have that language ability yet and are exposed to trauma, they're going to have a hard time not only expressing what it is that is going on or what it is that they're feeling, but they're just going to have a hard time understanding what it is that's happening to their body and why their body's reacting the way that it does around certain triggers in their environment. They might not really understand why I'm so hypervigilant, or why I'm starting to pace around, or why I'm having a hard time calming down, and they are not going to be able to express this to adults. In children who may have experienced trauma during early childhood, it may affect their IQ, and this is most likely related to problems in the language and memory abilities. Emotional dysregulation in terms of the ability to identify and regulate their emotions, sensitivity to noise, and problems with just auditory processing in general. Avoidance of contact and heightened startle response. We talked about how some of those kids who are just really jumpy when you try to give them a hug or even just put a hand over their shoulder, so just being really cognizant of that. Experiencing night terrors or aggressive outbursts. Confusion about assessing threat and finding protection because they can't really accurately judge the danger and the safety that's available within their environments. Fear of being separated from familiar people or places, and this can oftentimes appear like separation anxiety, or it can look like excessive clinginess to children who are maybe just getting admitted and are just having a really hard time regulating their emotions. And a lot of times these children may regress to more recent behaviors, and this is really referring to the older, like 4 or 5-year-old kids who may have started preschool already, started kindergarten already, that are regressing to these behaviors of maybe just using baby talk, bedwetting, crying, and things like that. And then in the school years, the brain starts building pathways that really helps children to do more conscious, more rational processing of what is going on in their environment and their experiences. And this growth enables them to manage fears, anxieties, and aggression, sustain attention for learning and problem solving, control impulses, and manage physical responses to danger. So as you can see, these are some of the things that we actually see in a lot of the kids here, right? Because they're unable to manage their fears and anxieties and aggression. And these are really important tasks that children need. And school-age children who have experienced trauma may experience just emotional swings as a result of that. Learning problems, exhibiting attention-seeking behaviors, whatever that may look like. Experiencing unwanted and intrusive thoughts and images. In the younger children who have trauma experiences, they're not going to have, it's less likely for them to have these like active maybe re-experiences of trauma, or like just a replaying of whatever it is that happened, whereas you really start to see that in school-age children where it can look like they're dissociating, or it can look like they're spacing out, but they might just be in this kind of frozen state where they're just, this trauma and this intrusive memory is just kind of taking over. It can look like preoccupied with frightening moments from the trauma, replay the trauma events in their minds, or they can develop these intense specific new fears as a result of just some of the reminders in their environment that reminds them of maybe whatever happened during that traumatic experience. And then it can also alternate between shy, withdrawn behavior and then just unusually excessive aggressive behavior or explosive behavior. And they may be avoiding previously enjoyable activities due to fear of reoccurrence of traumatic experiences. And this may be seen in children who were exposed to community violence, who enjoyed spending time outside. These are the kids that are going to be more withdrawn and no longer spending time outside doing the activities that they were enjoying before. And also they might have these thoughts of revenge that may come up when they perceive anyone as having done them any type of wrong. And when we're talking about people that are doing them wrong, we're talking about simple things like maybe the child refused to share his candy with someone. Simple things like that can trigger just these intense feelings of wanting to get revenge, to the point where some kids can even have homicidal ideations. So we really need to take some of those things into consideration. They can also start exhibiting sleep disturbances that it interferes with daytime concentration and attention. I think we're okay. Okay. And in adolescence, the prefrontal cortex of the brain just continues to build connections and just pathways that enable them to think abstractly, anticipate and consider the consequences of behavior, accurately judge danger and safety, and modify and control behavior to meet long-term goals. So this is when they start really developing some of those higher order brain functions. And this is where they also start to really developing some of those skills that are needed, not just to understand what's going on in their environment, but also to learn how to respond. What would be an appropriate way to respond to some of these things that are going on and that I'm experiencing? And in terms of modifying and controlling behavior to meet long-term goals, these kids might have a hard time maybe coming up with any type of treatment goals. That's what it might look like when they're here. And adolescents who have experienced trauma may have difficulty imagining or planning for the future, may engage in reckless and or self-destructive behaviors, Underachievement and school failure is going to be common. Sleep disturbances that might be masked by either just late night studying, just engrossing them in their studies, not having enough self-care for themselves, or the opposite, where they're just partying all night, doing drugs, drinking alcohol, getting drunk all night. It can look kind of either way, either of those two ways. Over or underestimation of danger, that can definitely lead to risky situations. Expectations of maltreatment or abandonment from maybe individuals who are here to even help them out, but they're just always expecting everyone to put them down or to be abandoning them at some point or another. And a lot of that is kind of stemming from these difficulties with trusting others. And in response to trauma, adolescents may definitely feel that they're weak, just strange, childish, or even just feeling out of control or like they're going crazy because they can't really understand this fear that they're having. They can't really understand this exaggerated physiological response that they're having in response to certain triggers in their environment. So they're going to be thinking, okay, I want to make sense of this, but I can't. What's going on? I'm just going crazy. And that's usually a lot of the times the way in which they're explaining it. They may feel that they're unique and alone in their pain and suffering. They may feel like no one can empathize with what it is that they're going on, what it is that they're experiencing. And this may oftentimes lead to anxiety and depression or intense anger, low self-esteem, and helplessness. And adolescents who have experienced trauma may use alcohol or drugs in an attempt to cope, in an attempt to kind of calm themselves down from these overwhelming emotions and physiological responses that they're having. In these teens, reminders of past trauma may elicit cravings for drugs or alcohol, especially if it's developed as a effective coping skill over time. It's maladaptive, but it's been serving them a purpose for one reason or another. It's helping them, not remember all of these intrusive memories, not remember all of these bad thoughts and things that were popping up before. Substance abuse further impairs our ability to cope with distressing and traumatic events. It increases the risk of engaging in risky activities that could lead to additional trauma. And mental health professionals must address the links that occur between trauma and substance abuse and consider referrals for relevant treatments. So that's kind of something to look out for when we're looking into discharge planning. And in terms of specific adolescent groups, I want to talk about just homeless youth, special needs adolescents, and the LGBTQ population. Homeless youth are at greater risk for experiencing trauma than other adolescents. Many have run away in order to escape these recurrent physical, sexual, and or emotional abuse without really realizing that they're putting themselves more at risk to be exposed to other types of trauma. And female homeless teens are particularly at risk for sexual trauma. And special needs adolescents are 2 to even 10 times more likely to be abused than their typically developing counterparts. And the LGBTQ adolescents contend with violence that's directed at them in response to suspicion about them being gay or lesbian, or maybe due to them coming out of the closet and declaring their sexual orientation and gender identity. And then the good news, I guess, I know we've just been talking about how all of this trauma, all of these acute and severe chronic trauma experiences can really impact someone's development. However, there is good news that children and youth whose development has been derailed by trauma can learn new ways of thinking. They can learn new ways of relating to others. They can learn new ways of responding to stressful situations. In fact, the cortex, which is actually the highest part of the brain, and is part of the brain that really is associated with reasoning and analysis, is continuing to develop throughout adolescence and adulthood. So these children do have hope for change, and there is potential for change. And this is oftentimes done by providing new positive experiences and examples. We can help traumatized children and adolescents build new neural pathways by bypassing some of those old ones. Rational thought and self-awareness can help children override primitive brain responses, and just this process of learning and rebuilding is just going to take time and practice. It's not obviously something that's going to take place overnight, but we just need to remember that there is hope, that there is potential for change. And now that we've talked about all this, what does this mean in our treatment here? What does that mean in terms of what we can do for these children? Well, for this first slide, it's really just more about things that we need to recognize, things that we need to remember, just assumptions that we need to hold, such as recognizing the exposure to trauma is a rule and not the exception. So regardless of whether or not a child has been exposed to trauma, every single child has the ability to benefit from trauma-informed care. Recognizing the signs and symptoms of child traumatic stress and how they vary in developmental age groups so that we can really be able to identify some of those things in order to have maybe a better understanding of the behaviors that can come across as being intentional a lot of times. And recognizing that children's bad behavior is sometimes an adaptation to trauma, like I said, that it might not be intentional a lot of times. Understanding the impact of trauma on different developmental domains and the cumulative effects of trauma, because I feel like most of the children we see here, they're not just exposed to trauma acutely. A lot of times it's this complex trauma that we've been talking about before, where it's just chronic and ongoing. And it's important to gather and document psychosocial information regarding all the trauma in the child's life in order to be able to make better informed decisions. And when these things are done, just whenever you do have the time, just try to look through their file, try to see, okay, does this child really have a trauma history? These assessments are done for a reason so that they can provide us with more information. So I really want to encourage you to utilize that. And then making a special effort to integrate cultural practices and culturally responsive mental health services. We kind of talked about this last week. Just being cognizant of what type of culture that they're coming from, not just in terms of ethnicity, but SES, religion, whatever that might be, and also considering how our culture and where we're coming from really plays a role in that relationship. And also assisting parents and caregivers who have secondary adversities and traumatic experiences of their own, maybe by encouraging them to receive their own treatment because they might not be in the place to be able to provide the type of caregiving that the child needs. And identify and build on family caregiver protective factors. The last 3 points are really talking about those protective factors that we want to be able to strengthen and build here during their stay that we also talked about in the first presentation, and also helping build protective community factors by helping just connecting families to more outside resources. What other resources can they really utilize that's out in their community? Providing specific groups. These are the groups that we're doing here, the psychoed groups that build and strengthen those protective personal factors for children. Just any type of skill building group, whether that be social skills, emotional regulation skills, anger management skills. There's all sorts of groups that we do, and that's why it's so important. And for those who do work with parents, just providing psychoeducation to caregivers on providing trauma-informed parenting. It's really the same idea as just that trauma-informed care that we talked about before, just helping them understand and have that mindset and that shift in perspective in the way in which they're understanding and really conceptualizing the child's behavior and the way that they're presenting, offering a secure base of love and protection and what that also brings. Being emotionally and physically available in order to increase that sense of protection for the child at home. And ways to identify and respond when a child is expressing their needs. So a child that's expressing their needs can look like, especially in young children, they might not have the verbal ability to say, I need this is what I'm feeling, so this is what I need right now. It's going to look like tantruming behavior. It's going to look like defiance. So if just being aware of that and maybe just providing, maybe going over it in the sessions with the parents. Okay, so these are some of the things that you can look out for, and what are some ways we can ask the child, what is it that you need? How can I help you right now to feel better? Rather than letting it get to that point where the child is actually having a meltdown. And like I said, just providing guidance and example, going through some examples of what it is that maybe we see on the units and paralleling that to what it is that the parents are seeing at home. And then recognize that interventions have the potential to either exacerbate or decrease the impact of previous traumas. So this just is referring to just being aware of the way in which our responses and our reactions can be re-traumatizing for some of these children. It can be triggering for some of these children, so just being cognizant of that. And lessening the risk of system-induced secondary trauma by serving as a protective and stress-reducing buffer for children. And we can do this by developing trust with the children through listening, frequent contacts, and honesty in order to mitigate previous traumatic stress. And this is really referring to the importance of building that therapeutic relationship with the child. And I know we've stressed this before, that you don't have to be an individual that does therapy with the child in order to bring about therapeutic benefit for someone. There's a lot of people who work in the offices, maybe behind the nurse's counter, and you feel like I don't have that much face-to-face contact with the patients a lot. But even if it's just, you know, for 5 minutes or 2 minutes when and the kids are up by the nurse's station, you know, just really lending them an ear, really letting them know that they're being heard, you know, really listening to whatever it is that they're there and letting you know, because a lot of times they're coming up there because they want that attention. They need someone to listen to them. They don't have that in their environment back at home. Let's see. And then avoiding repeated interviews, especially about experiences of sexual abuse, and avoid making professional promises that, if unfulfilled, are likely to increase traumatization. So this last one, it can be kind of confusing because it might be like, what is that really referring to? Can anyone think of any examples of what that might be? What might be some unintentional promises that we might be making that we're unable to fulfill and that might be increasing traumatization? Can you guys think of any examples?
You're going to feel better.
Absolutely, yeah. And things like that, like, you know, you don't really even think about it because we're trying to, you know, help them calm down, and we're genuinely trying to make them feel better and saying things like that. And then to them, it's like, oh, like, I told you we can't trust her. She's like telling me lies, or simple things like that, even though you were saying it with good intentions. And did I see another hand over here? Yeah.
You know, I think on this whole thing, I'm looking at like our population today. When you have a majority of the population that has been traumatized and is over the top, my thing is, how do you get control of it? I mean, because one child is set off, and it just goes throughout the day that they set off the next one and the next one. I mean, don't you think, Chris? I don't know what you're talking about. Stop it. You know, so you have all of these children, and you don't have enough calmness or, you know, one-on-one-ness to get them to a place. I mean, it's
But see,
really.
that's why, and as we discussed, you divide and conquer.
Mhm.
You divide the groups up. You leave the ones out in the million that have that, and then we have the extra staff to do, you know, like I was with the one patient for most of the time, someone was with the other one.
Right.
And you just wean them out that way so that the other ones can continue the program, and then they get that one-on-one so we can get things managed and medication statements and sent and different things. And you prevent them from basically doing that to everybody.
You know, interrupting the whole milieu.
Mhm.
Right. And I think the consistency of, you know, core staff, I mean, I see that with them because I'm not core staff, but that they can walk on the unit, you know, kids automatically listen up, are looking for direction from them. You know, the person that comes in there that's new, that's the difficult thing. How do you establish any kind of rapport with that child when you're only there for that 8 hours?
Well, and sometimes
You know?
even the core staff have this program, you know, there's one patient today who, he was acting up and he was in the hallway, he ran up the unit, he looked up the unit, a little 5-year-old little guy, and he saw a day treatment staff, which he recognized. And we were teasing that day treatment staff, and you were really scary because that kid saw that day treatment staff. He ran back to the unit because he didn't want that day treatment staff, not because it's the day treatment staff, it's scary, I teased him about that, but he didn't want the day treatment staff to see him being naughty.
Right.
And that was the whole thing. He looked up and he was like,
He took
uh-oh, and he ran back to the unit because he didn't want the day treatment staff to see him being naughty. So sometimes it's even
No,
that sort of
I
thing.
agree.
And they've been with the inpatient staff for a week and a half, but, you know, sometimes it's just that kind of thing.
You know, there's days they don't want me, and there's days second
Right.
shift comes on,
Mhm.
and they're like, no, I want you to stay, and they hug my leg, and, you know, they're just, they won't let go. And it varies, it depends on what they're feeling, what they're going through, and what they want, because we all give them something different.
Right.
So maybe you come on new, and there's someone who wants you because you have something different to offer
Mhm.
them, that's
same person to them.
Right. Or a new one. But, so I guess. It's just
I
difficult.
think there's
Yeah.
two things that I would comment on. One is, it doesn't often take long to develop a therapeutic relationship
Mhm.
with a child. So, I mean, there are some children who maybe have disturbed attachment, and some over-attaching, maybe some don't attach, so it might take a little while in those cases. However, if you respond to them in the ways that we've been talking about, where you give them the message that you're interested in hearing what they have to say, you're interested in meeting their needs, you're kind and gentle.
But how do you do that when you have 5 over here that are trying to claw at the kid, you know, screaming at you, no, I wanna hear what you have to say, and they're over here, ah!
Sometimes that means engaging with them all at once. So maybe, how about we all play a game of Candyland, you know, if you're with the little kids, because it is
Yeah,
difficult
it's
to do
difficult to
one-on-one with
Yeah.
every single
Yeah.
kid.
Yeah.
But, you know, being able to work with all of them at once, playing a group game, that gives you a chance, one, to make connection with all of those kids, as well as kind of set an example for how you know, you want them to behave, like, oh, so-and-so is using his manners, that's really nice, I like the way this person is sharing and being a friend. It makes me really happy when you ask before you take something. There's so much that can happen in one little game of Candyland that can build a relationship, as well as give them cues for how you want them to behave later on, and build those kind of relationships, so that if they see you down the hallway, they don't want you to see them being naughty.
Oftentimes when we see so many kids being triggered or acting up at once, there's something happening in our environment that's encouraging that. And so we need to step back and figure out what is it that's
I totally agree, I
resulting
guess
in
that's what I'm trying to get to,
Mhm.
whether we have more, programming for staff that says, you know, maybe these are some tools that you can use. Because, yeah, you can feel that.
You can feel it. Maybe it's
You can feel it.
transition time, and we didn't do a good job preparing them, having a transitional activity and moving into the next activity. So their anxiety level is up,
Right.
and they're all, maybe there's, suddenly everyone has a need and is feeling their needs aren't being met, so they're all trying to get on top of the other to get your attention at once. So you can acknowledge that, but it seems like a lot of people need attention right now. I think this is what we can do, you know, you set the example, let's sit in the circle and I'll hand the ball to you, and it's your turn to tell us what you need. I wanna make sure that everybody gets their needs met. We're feeling a little worried about what's going on right now, we look a little worried. You know, and reflect that feeling and then engage them in activity. But it is challenging to deal with many traumatized kids at once. We do know, though, from the literature, that probably about 80% of the kids on the unit have a trauma history at any time.
Right.
And so it's a commonality. And so the way we can set up the system, and that's a challenge for the system, to be able to have new people come in and be able to just smoothly step in. Because then there has to be very consistent structure.
Well, that's
Yeah,
one of
you know,
the big
so you know
frustrations,
at
you know,
10
you
o'clock
want
that
to be,
there's-
everyone say the same thing. Breakfast is at 8 o'clock. You know, the next one, not somebody else going, no, now it's at 7, or now it's at 7:30, or, you know.
Right, and
I
even
mean,
how you wake them up. Does somebody
Right.
yell down the hall, time to get up? Or does someone go in and each morning gently say the same kind of phrase, you know, good morning, I'm so excited to be here, we're gonna have a good day today, remind them of their task, and, you know, start it in different ways. Is it the same every day, or does it depend what staff comes in and might say, hurry up, you're running late, get up.
Right.
Starts off in a very bad, you can see what I'm saying right there. That is not, you know, like,
Right.
you don't know, you come on and it's like, we're supposed to be at breakfast in 10 minutes, the kids aren't even up yet. You're trying to pass
So
that
now
on to
we're
them.
anxious.
So we're anxious and we're
Mhm.
passing that on to the staff.
And I think that that's a good point. That's actually something that we'll cover in the last presentation. But being aware of how stressed out we are. I mean, right now, it sounds like we've got a lot of kids there. There's been numerous codes, and that has an impact on our ability to do our job, right? When we're
I
stressed.
mean, nobody wants it to get to that kind of level that you
No, of
can't
course not.
get that child under control. I mean,
No.
it feels defeating, I think, for us as staff as well.
Of course.
Absolutely.
Of course, so that means when we have these, you know, these weeks that are very stressful, being supportive to each other and also being compassionate to ourselves and understanding, okay, I might need to take a minute and take a deep breath before I charge back into the fold, because it's not just doing what's best for you, it doesn't make you
and then being around all these other children who are going through the same thing, and like you were saying, just all they're triggering each other, and how overwhelming that can be.
Overall, I have to say, I think that it worked well doing that.
Oh, I totally agree. I think it could have been
Because
way
not only
better.
that, but I also let the children know, you're in group A. These are your staff members today.
Mhm.
If you have needs, these who can address your needs. Because when we have a lot of staff members, I don't want to confuse them either as to who do they go to when they need something. And I noticed it worked well today because a lot of them that I used to meet there every day, even when we're in the cafeteria, sat with their group and did not even come up to me to ask me for anything. So I knew that they were comfortable knowing who was helping them today, who was with them, and my group stayed with me and knew that whatever needs they had, I could meet as well. So it worked well that they weren't confused either, like, wow, there's 7 people here today, who do I go to?
Right, you made it
know,
predictable, you took away
Exactly.
the ambiguity, you made it predictable, they knew, who they needed to
You know,
talk to.
and we did things off unit. So transition wise, we knew that if we had to transition to another area, that the other ones were busy doing something else, so they didn't see the transition. Or vice versa, and wonder, well, what are they doing now? How come they're doing this, things like that.
Mhm.
And
Absolutely.
even taking them off unit, we did a group in the cafeteria, played some board games, while the other group was doing their first part of social work. So it was really setting it all up to, and you know what, no matter how much you do it, you're gonna have 1, 2, 3 children in the day room having issues and having near codes and things, because that's why they're here.
Right.
But it's being
And
able to
depending
take,
upon where
it's
they
being
are in
able
the
to take
program.
the other 13 and allowing them to get
Manage them.
treatment and to get programming until we can get the other ones under control and not being disrupted by this. And it's a process. And
Yeah.
and everybody, it's hard for people who don't work on the unit all the time to say, come on, and it's reading all these directions and say, okay, this is your group, this is what you can do with them. You're a one-to-one. That's your patient. You spend one-to-one time. If she wants to go for a walk, guess what? You're there for her. Take her. She's going to cafeteria to eat, get her out of the kiosk, take her, you're with her. It's okay. You know what I mean? So it's really just,
And I think you're making a really good point. It's important not just to clear up that ambiguity for the kids, but also for
Staff.
Because if staff doesn't really know what they're supposed to do, it makes it more difficult for them to help.
no, most of us are
It's
parents.
all communication.
Right, most of
You
us
know?
have had dealing with kids, most of us are parents, and you get those kids and you kind of know a little something to do with them.
Definitely.
Dig into your bag or your brain and you come up with something like, hey, let's try this. Sometimes they like that, like, oh yeah, I'll do that, or silly things. So it's some people are a little stressed, they hear the numbers, but once they get there, it's just not that bad.
I think having a game planning that you had to do that.
Yeah.
I'm glad I'll be good to tell them.
No, and I think this is good. I think this is like an ongoing conversation that we should always be having, and not just during these presentations. And I feel like it's really important. Otherwise, it's like we're just frustrated, and it's like, what are we going to do with this frustration? We're just going to hold on to it and then be expected to work at our best with the children, and that's hard to do, right?
I try to make things as less frustrating for staff as well, because they're coming to the unit. I do it every day, they don't. So I have to break it down, so you guys come on and you guys know that this is what I'm gonna do, and
I totally
I don't like to
appreciate
see
that.
you guys stress either, because then they see it.
And then it stresses you out, and it stresses everyone
I
else
say,
out. Yeah.
So-and-so looks very stressed, and I'm like, no, you're fine.
Mhm.
I know that.
You're fine.
Maybe, just like that.
Yeah.
This is always run like that.
And it's surprising how kids can pick up on those cues so quickly because, and I think a part of it is like that trauma. They probably got it at home all the time. Mom's mad at me, like she's really anxious right now, so she can recognize that in strangers where, it might not be a frustration towards them, but that's what they might think of it as, right? Yeah.
Well, and I think Tracy doing what she did today made us part of the process.
Absolutely.
This is who you're gonna have, this is what you need to do for her. These are her things that may trigger her or whatever, but, and that clears up a lot of things.
And it's all trial and error. We're all gonna have things, we're all gonna have incidents, and it's learning and saying, okay, this is something similar, we can do it this way because it doesn't make sense.
Right.
And I think the divide and conquer plan is great because it gives the children a secure base to kind of work off of. If you think of attachment, right? And these children probably, if they don't have, that secure attachment, they need it here. They're always looking for it somewhere. They have a base that they can go back to, whether it's that same group of staff members or same group of students or patients, whatever that might be. So rather than it being this 20-something group of patients that they don't even know who to refer to when they're needing something or wanting something. And a lot of times when the environment is chaotic, what they really need is that structure, and it sounds like you really got into it right away. And a lot of times sending them to their rooms is not providing structure at all. That's absolutely unstructured, because they're just stewing in their rooms, getting angry rather than being out here and really working on a structured activity. Simple things like playing Candyland is a very structured activity that they can engage in and things like that. So I thought that was great. Yeah. Okay. Anyone else? I don't want to. No, it's okay. That's great.
Kelly just had fun.
Yeah, it's all right. The next few slides, we'll go through them pretty quickly. So far, we've kind of reviewed the different ways in which exposure to trauma kind of causes the brain to develop in a way that will help the child survive in a dangerous world. And children have, and what is a metaphor that's commonly used in some of the trauma literature, an invisible suitcase that they take everywhere that they go with them, that's just filled with the beliefs that they have about themselves, beliefs that they have about others, beliefs that they have about the world in general. And the invisible suitcase is often filled with just overwhelming negative beliefs and expectations about themselves, such as I am worthless. Next slide. I am worthless, I am always in danger of being hurt or overwhelmed, I'm powerless, and towards others such as, you're unresponsive, you are unreliable, you're lying, I don't believe anything you're telling me, you are or will be threatening, dangerous, or rejecting. So these are some of the beliefs that they're taking everywhere that they go and that they're using to relate to every single person that they're interacting with. So I want to kind of use a case example. So Javier, let's consider Javier's suitcase and how we can understand his behaviors given what we know about the impact of trauma on development. So he is 15 years old, and these are some of his presenting behaviors. Verbal, physical aggression, destroying property, fighting with peers, argumentative, defiant with adults. Quick to anger, socially withdrawn, poor concentration, easily distracted, difficulty in group settings. Is this a pretty common presentation we're seeing here on the units? I would think so,
And I
right?
think if we stopped right here and we got this and we were asked to make a diagnostic impression.
I'm just going to go there, exactly. Just based on these
Just based on
behaviors.
this, we'd say ODD, or
ADHD, yeah, those are the
Yeah,
two that
first
mine
two-
goes to.
Two things that we would probably think of
Mhm.
with this particular.
Yeah, and I'm definitely guilty of that too. When you see a child that's just unable to attend in groups and is just fidgeting and is just setting everyone off and is having a hard time just maintaining his body, you're going to think, okay, someone give him some stimulants. What's going on, right? But, like we were saying, when we're really considering what is going on in their history, and to the next slide, he's exposed to multiple types of traumas, exposed to domestic violence starting age 6. And if we're considering that this has been happening up until now, that's almost 10 years that this is happening. Waking up to mother's screams and the sound of his father throwing furniture. Imagine that happening every night. Neighbors have called police several times, but nothing was done. So once again, it's kind of reinforcing that belief that the world is unsafe, no one can protect me. Physical abuse, being slapped and pushed by the father since he was 8, and it sounds like this was starting to happen once he got big enough to start kind of intervening in the parents' fight, but the abuse just got kind of directed towards him. And then this is also when his problematic behaviors also started in school, so maybe he was getting suspended and then getting in trouble for that at home. Verbal and emotional abuse, where he's getting cursed and yelled at, not only by the father, but also by the mother. Maybe mom doesn't want, him to be intervening. Maybe mom doesn't want people finding out about this and him just trying to do something about it. So just getting yelled at by mom and dad, being threatened for harm by the father, and also threatened abandonment by the mother. Maybe she was threatening to leave him with the father and then leave on her own, whatever that might be. If you imagine for a young child, and even for a 15-year-old, that can be very scary. So based on what we know, based on what's in Javier's suitcase, what are some of the beliefs that he might be having about himself? Based on his history, based on some of his behaviors, what is he thinking about himself. Mm-hmm. I'm not good enough, definitely. Is he feeling pretty powerful? No, right? I'm out of control, I'm powerless. I do everything wrong. It sounds like he's tried to intervene several times, and if anything, maybe that made the fight worse, right? Everything that I do is wrong.
Even he's unlovable.
Mhm.
His two caretakers are the ones that abuse him.
Absolutely. And then how about his beliefs about others? What is he kind of projecting onto everyone else?
Unreliable.
Absolutely. And no one will protect me. These staff members are saying that they're here to keep him safe, but I can't believe you. No one will. My parents weren't able to protect me, and they said they were going to. So how can I believe you guys, right?
The police weren't able to protect
Mhm.
me. They come to my house and nothing has changed.
And another one, maybe no one listens to me, right? No one listens to me. I try to express my needs in my own way. Whether to him, expressing his needs, like I said, might have been just getting really angry and being defiant, but to him he's thinking, oh, I expressed my needs, but no one met them, so he's going to think in here, oh, there's no point of me trying to reach out to anyone, no one's going to listen to me anyway. So those are definitely some of those beliefs he might have. And just how about the world in general? Is he seeing the world as a safe place? Definitely not. Everything's going to seem like a threat. Everything's going to seem unsafe.
And maybe the way to keep yourself safe is to keep others at a distance.
Absolutely.
Perhaps you do that by acting out
Mhm.
and appearing violent and scary, and people will
Exactly. And that's probably worked for him, right? That's probably worked for him up until that point. We talked about how these survival skills really become a coping skill after a while because it's working for them, it's getting them what they want, but it's very maladaptive, and a lot of times they have a hard time really realizing that. So kind of thinking about repacking this suitcase with new beliefs, new thoughts, it's kind of referring to that earlier slide on the process of unlearning and rebuilding, that these children do have the potential to change, that's kind of the positive point here, that how can we repack his suitcase with more positive experiences and beliefs? How can we promote resilience in this child by making him feel safe and capable and lovable? And I think it's everything that we were kind of talking about already, but if you guys have any more ideas, I think it's that structure, right? Providing structure can really make a person feel safe. Sometimes it's during those times where they don't know what to do with themselves, during those transition times that are just not structured, that they can feel really unsafe. What are some other things that we can do as a unit, as staff?
I think one thing to pay attention to in this case is he was very young when these things started to happen. And so we know from the beginning of this presentation
Think
that
about
his brain wasn't
Absolutely.
developed yet
Mhm.
fully, because he was very young, and it was these positive experiences that were causing the brain to develop completely. Well, he wasn't having those
Yep.
experiences, and he was being left in that alarm phase. And so those interactions between that right brain, left brain, logic, language, being able to use our words, like we say, use your words, wasn't being developed. That pathway was never developed. So now when we respond to this child, when we try to respond to him with that logic and talk with me, tell me what's going on,
He's not going to be
he's
able,
not
he
gonna
doesn't
be
have
able
the
to,
skills.
because he doesn't have those pathways. So we have to go back and take him through those experiences so his brain, not just to teach him a habit, but to let his brain actually form the structure necessary to be able to do those. So that's where I think all of our sensory interactions come in, because this is where this child was experiencing his trauma, was in his sensory area of his brain. That's what was functioning at that time in his life. And so when we're engaging in sensory activities, we're being able to reach him in a way that he can be reached, and then provide ongoing
Exactly.
opportunity.
So understanding the trauma that they experience at these different levels can give us some therapeutic insight in how to address that now. So like Dr. Jody was saying, if they weren't receiving these sensory experiences when they were young, and that's one of the reasons that they're having sensory problems now, how can we work that into their treatment? How can we provide, some sensory experiences like sand trays, or even doing, like the deep pressure massages or things? Well, it's not necessarily massages, but they have different sensory activities that you can do. And also, like Dr. Jody was saying, keeping in mind that traditional talk therapy or reasoning with kids at this level might not work, because that hasn't developed.
But the other thing too is sometimes you have generations that haven't developed any of this. And isn't that what we see? You know, these kids come, especially like adolescents, when they get, where they're so angry. And we'll see them in control of themselves and doing well and get on the phone with mom and lose it. Because they're arguing with her. I mean, they're not having a normal parent-child interaction. You know, the mom's antagonizing. You know, you can tell by the way the phone conversations go. So, you know, the big frustration for some of these kids is, great, you're giving me these tools. I go back home. I'm still talking to a wall here.
Right.
And so,
What does our social worker tell us? That's right, that's
What
what I
is
looked
it?
at, that's a family therapy.
Uh-huh.
And in the slides today, we talked about
Yeah.
teaching parents trauma-informed parenting and building parents' resilience.
Exactly,
against
promoting
trauma.
some of those protective
Yeah.
factors in the families.
Protective factors in the family, and especially it's key with adolescents, because the adolescent's world revolves around their friends and their family, right? There's key relationships in their life. So those are the triggers that are gonna set them into the most destructive behaviors. The most frequent precipitant to a suicide attempt is a conflicted interaction with a parent or peer. And so those are the key things to watch for, because that's what they value the most. at that
Absolutely.
time of their life.
And you're exactly right. When you see this type of trauma, this complex chronic trauma, it typically does span generations, and it makes sense, right? If someone grows up with this type of history and it's never been addressed, it's pretty likely that they're going to, you know, interact in these same ways with their children. So you're exactly right, having an idea of what the parents have gone through. So like Wendy was saying, you can address that by psychoeducation, as well as encouraging them to get their own, you know, their own therapy and address.
And I think we
their
just notice this the most in our young patients, because our real little ones, typically the families are still in the midst of this trauma of their own life. The parents are young, they may, not have ever even developed out of adolescence themselves, so
Yep.
they haven't developed protective factors. They maybe haven't ever even engaged in their own therapy yet. And so those are patients that we often see come back into treatment a lot, because we're not able to take them far enough until we can get the parent on board, involved in their own treatment. So our treatment is too provocative for them. It triggers back all of their own trauma, and it's really hard for them to move forward until all those other things.
Exactly. And the last slide is just something for you to hold on to. It's just some tips that I found on the literature, because I really want to emphasize that, a lot of people have the misperception that promoting resilience and providing trauma-informed care means that we're not really providing the redirections or the corrections that children need, and that's not what it means. It's not about being soft. It's not about giving the kids a free pass and letting them do whatever they want. It's about how in which we're really approaching that, how we're providing these redirections, how we're responding. And I think this is something to keep in mind also when you're having family sessions or meeting with the families, because parents need to know how to do this too. And there's only so much, like you were saying, that we can do. They need to be able to move that on into the home setting. So just some things to keep in mind. And a lot of it are things that we've already talked about, just being able to, provide positive reinforcements for every maybe correction, and just so that they feel less shamed or less triggered, because a lot of times that shame is what triggers a lot of these explosive behaviors. So we want to be able to deliver these redirections and cues in a way that's respectful, in a way that we would like to be cued, right? Just think about it in that way.
I think that's a good instance of how trauma-informed care is fruitful to anybody.
Exactly.
There's good research in
Everyone can benefit from it.
Adult marriages of
Exactly.
non-traumatized people, that you need to give 5 positives to every critical feedback you give to your spouse in order for them to be able to actually hear it and make a change. So it's not much difference than
Exactly.
what we're doing for our
And it's
children
kind of
that
what
trauma.
Shirley was talking about earlier too, that if you feel like your own emotional response to the child's behavior is not calm, and you feel yourself getting emotional, and you just know that there's no way I'm going to be able to, interact with this child in a respectful, maybe appropriate way, just step away. That's okay. That's for your benefit, for the child's benefit, and I'm sure that's something that we would all encourage all the staff to do. So just some things to keep in mind. And these kids need repeated corrections. They're not gonna, these brain pathways that we're talking about, it's not gonna happen overnight. They need reminders. They forget it really quickly. And it's okay as long as we're doing it in a manner where, you know, these children know that we're doing it with care. Now, it's not meant to be punitive. Exactly, exactly. Everyone take a few minutes. Exactly. Exactly.
I think what the first point you made up is the most important, because I hear a lot of people say, oh, trauma-informed care, that means, you know, that we do whatever the kid says, and, you know, and I think, you know, to drive that home, it's a kind way to set firm limits, to be consistent. It's not that we're going to do whatever the kid wants to do, but that we're going to be doing it in just a different way. Because I kind of see some eye rolling sometimes on my unit, like, oh, trauma-informed care, here we go, you know. But it's really a different way to look at the child.
Definitely. It's all about accountability. It's all about, you know, the expectations that we're setting for them and how structured and how much we're following that consistently. And I think that's really important. So yeah, I think that is it. And next week we'll be talking about secondary traumatic stress and just the ways to ensure our own well-being and how that affects the work that we do with the children in this stressful environment. So I thought that might be a really helpful way to kind of end up the series. Thank you for being here.
Thank you.